it seems that we didn't save the changes. Anyway, I've already highlighted this table, so I'm not going to dwell on that any further. But what I would like to do is highlight the results of the Orion study, which was published a few years ago. It's a real-world safety and effectiveness that looked at the safety and effectiveness of insulin glargine 300 in people with type 2 diabetes who were planning to fast during Ramadan. So this was a prospective observational study, and the primary objective was to determine the percentage of people that had more than one episode of severe endosymptomatic documented hypoglycemia with self-monitoring of plasma glucose of less than 70 milligrams per deciliter during the pre-Ramadan, Ramadan, and the post-Ramadan period. So what is the, who were the patients that were involved in this study? So you can see the mean age is around 54. Mean BMI is 29, and the mean duration of disease of diabetes was around 10 years. The risks associated with fasting, the majority of them, 82%, were in the moderate to low risk, and a very small percentage, 2.9%, were in the very high risk. And the regions that participated in the trials include the Indian subcontinent, the Levant, Egypt, and Turkey. We had a good representation from the Gulf countries, and a few patients were enrolled in Canada as well, so quite well represented. Now, the majority of the patients were advised to adjust their insulin dose based on the IDF-DAR 2021 guidelines, and overall, about 75% of the patients were receiving more than 2 non-insulin antiglycemic agents prior to the study, of which the majority of them were on biguanide, as metformin, about 74%, followed by the DPP-4 inhibitors, the sulfonylureas, and the SGLT2 inhibitors. So if we look at the, duration of fasting, we see that the majority of the participants, 85% of them, were able to fast, throughout the month, and only 10.8% of them needed to break their fast. So what about the adjustments in the glargine dose? There was very minimal dose adjustments that happened during the study. 94.1% of the patients experienced no interruption in their glargine treatment during Ramadan. So what about the proportion of patients that had either severe or symptomatic documented hypoglycemia? And as you can see there, between pre-Ramadan and Ramadan and then post-Ramadan, there wasn't a huge difference. There were none of the participants actually experienced any severe hypoglycemia during Ramadan or the post-Ramadan period. And then if you look at the event rates for any severe or symptomatic documented hypoglycemia, we see more or less the same. So let me now turn your attention to the glycemic control. The starting HbA1c was around 8.1% before Ramadan. And after Ramadan, it went down by 1%. As you can see there in the green, represented by the green bars, it was 7.6%. And the same can be seen with the fasting plasma glucose as well. There was a significant reduction from 144 to 128. What about the adverse events? And if we look at the adverse events, they were more or less the same throughout the study and during Ramadan. There wasn't any signal for any sort of serious adverse events, and there wasn't any mortality that was seen in the study. There was a sub-analysis, again, also that was done for the population that was in the Gulf region, so Kuwait, Qatar, Saudi Arabia, and the UAE. And again, we look at the hypoglycemic events. Fewer than 5% of the population experienced a severe or a symptomatic documented hypoglycemia. And the majority of these actually occurred in the pre-Ramadan period. And then if we look at the event rates, it's more or less the same. We don't see any severe hypoglycemic events, whether it was pre, during, or post Ramadan. And if you look at the sub-analysis for the Gulf region as well, not much difference as the rest of the cohort. Again, a significant change in the HbA1c before Ramadan from 8.3 to a drop of 7.7%. And the same was seen with the fasting plasma glucose as well. So then what this study highlighted is that the incidence and event rates of hypoglycemia were very low. And in a meta-analysis, Glargine 300 provided similar glycemic control to the first-generation insulin, with a low rate of hypoglycemia in individuals with type 2 diabetes. And as we've seen, the incidence and event rates of hypoglycemia was low in the overall cohort, and it was also low in the Gulf countries. So to summarize then, during Ramadan, individuals treated with a second-generation basal insulin, such as Glargine 300, in a real-world setting, were able to fast safely with no risk of hypoglycemia and a reduction in the hemoglobin A1c post-Ramadan. So that is one way of trying to mitigate hypoglycemia is, take an insulin that will give you a low risk of hypoglycemia. The other way is to combine the basal insulin with a GLP-1 receptor agonist. Professor Wasim highlighted the results of the Liral Ramadan and the Lixiram study, but the Soliram study also gives us good insights on the real-world safety and effectiveness of eyeglass Lixi in people with type 2 diabetes who plan to fast during Ramadan. So the objective of this study was to look at the safety of the fixed ratio combination of insulin glargine with lixisenatide in individuals with type 2 diabetes who are planning to fast during Ramadan. So the primary objective, again, was to look at the proportion of people that would experience one documented hypoglycemic event of less than 70 milligrams per deciliter, or a severe symptomatic hypoglycemic event during either the pre-Ramadan, Ramadan, or post-Ramadan period. So who are the participants? There were a total of 420 individuals that were included from 9 countries shown there on the map. Average age was around 57. The average BMI in this study was much higher than in the Orion study. The BMI was around 30, again with a long duration of diabetes of greater than 10 years. And they were also on concomitant anti-glycemic agents. The hemoglobin A1c before Ramadan was around 8.2%. So what are the anti-glycemic therapies that they were using during Ramadan? As expected, the majority were on biguanides. There was a good proportion, about 43%, that were also taking sulfonylureas and 40% that were taking SGLT2 inhibitors. There was a very low use of DPP4 inhibitors, of course, because they were already on an incretin therapy, the lixisenatide, and a low use of TZDs and glinides. And most patients injected the Igla Lixi in the evening. Minimal adjustments were made to their anti-glycemic therapies from the pre-Ramadan to the Ramadan period. So were these patients, these individuals able to fast during Ramadan? Yes, 93% were able to fast the whole month. So the mean number of fasting was about 28. And of the 31 participants who did have to break their fast, some of the reasons that were identified was because of travel, pre-existing conditions. Only 4 had hypoglycemic events, and 6 of them were women during the menstrual cycle. So what about the primary endpoint? And it was encouraging to see that the incidence was low throughout, of hypoglycemia was low throughout the whole of the study, and even during the fasting hours of Ramadan. And then no severe hypoglycemic events occurred, so there was no signal for any increase in the incidence of hypoglycemic events. Then you want to look at the glycemic control. So change in A1C, as you can see again, a significant reduction from 8.2 to 7.5. And the proportion of patients that were able to get to the hemoglobin A1C targets of less than 7% was much greater in the iGLYC arm. The proportion that got to the 7%, as you can see there, is higher post-Ramadan compared to the pre-Ramadan period. So did this come at the expense of an increase in the body weight? And as you can see, in fact, there was a slight decrease, less than 1 kilogram in the body weight between the pre-Ramadan and the post-Ramadan period. What about the adverse events? As expected, most of the adverse events were gastrointestinal, but they were not severe enough to lead to treatment discontinuation. So to conclude then, iGLYC is another tool that we can use to provide a safe and effective treatment option for people with type 2 diabetes who intend to fast during Ramadan. And this is my last slide, again, just to reiterate the strategies to optimize safe fasting. I cannot emphasize enough that the pre-Ramadan risk assessment needs to be done regardless of the type of diabetes or medication that the individual is on. Self-monitoring of blood glucose is extremely important. And the other important factor is about breaking the fast. Patients should be cautioned and counseled that they should be willing to break their fast if they get into either hypoglycemic or hyperglycemic events. And with that, I'd like to thank you all for your attention, and I hope I've gained time this time for more questions.
Yeah.
Thank you.